be able to.
All right, terrific. So again, welcome everyone. This meeting is being recorded. And today we are really very, very pleased to have Travis Trolley from Utah joining us to describe the Utah program. Travis, a warm welcome. I appreciate that you're just coming off of some leave, and so really appreciate your taking the time to help this team really understand some of the other alternatives that other states have employed. We're also going to be, just by way of reminder, this group has two charges. The first charge is to look at the short-term emergency supply strategies, and the second job we have is to look at long-term cost strategies. We've spoken about how this is being used in other states, both of these two dynamics. And so we'll be going through just a quick summary. And again, for folks who were here last time, really appreciated Jane Beyer of the OIC asking us to do a summary by state. Haley has done a fantastic job pulling together a summary review of other states. We'll do a potential solution for Washington State that we will put in the report, and then we will go through Poll Everywhere questions to be able to respond to that sort of as a team, what our thoughts are. And then, so we'll do the short term, and then we have a cost analysis update, then we'll do the long term, and then we'll talk about some next steps. And importantly, there will be a 10-minute break in between those two. And I also appreciate that there are some substitutes in today's meeting. We had a few of our members not able to make it today. I'm thinking, Nonya, if you could please go through the list of people who are here as substitutes.
Okay, we have Sherry, who will be substituting for Barbara. If you, Mary, do you want them to introduce themselves?
That'd be fantastic.
Okay, perfect. We could start with Sherry.
Okay,
oh, Sherry,
sorry.
I see. Oh, sorry,
Okay.
no, it's okay.
Yeah, had to get myself unmuted and videoed again. So I'm Sherry Meyer. I'm a health policy analyst with the Office of the Insurance Commissioner, and I've been there for almost 2 years now. So
Awesome. Welcome, Sherry.
yeah, thank you.
And then Ryan, here for Donna.
Okay, there I am. Hi, so good morning, everyone. I'm Ryan Pistoresi. I'm the Assistant Chief Pharmacy Officer here at the Washington State Healthcare Authority, and so I am filling in for Donna Sullivan today. So thanks for having me.
Fantastic. Welcome, Ryan.
And we have Kelly, who's here for Leah.
Hi, good morning, Kelly Memphis. I'm Director of State Government Affairs here for the Healthcare Distribution Alliance. Leah had to do some travel, so I actually will be attending about the next hour, and then my other colleague, Matt DiLoretto, will be subbing in. So we just really value this group and wanted to make sure we're able to attend it. So thank you for accommodating us, and nice to meet everyone.
Wonderful. Thank you so much, Kelly. And could I ask that Matt just puts in chat, or you put in chat when you're doing the transfer, so we can make sure Matt feels welcome and is part of the team as well.
Sure, sounds good.
Great. Thank you so much. All right. Any other opening business that we need to cover before we turn this over to Travis?
Mary, this is Lita. I'm just going to remind people that we do get the meeting transcribed. So if you could state your name every time you speak, it's easier for the transcriber to identify the speaker. Thank you.
Great. Thank you, Lita. Great reminder. So with that, I'll turn it over to you, Travis.
Mary, thank you, and thanks for the invitation and having me here. I'm Travis Tolley. I'm the Director of Clinical Management and Provider Contracting for Public Employees Health Program in Salt Lake City, Utah. Had some earlier conversations, and in fact, some historic conversations with some of you on this call. My recollection of the the discussion leading up to this was that we wanted to answer some questions, and so I can certainly present and ramble on for a few minutes if it's helpful. If it's more helpful to allow the group to ask questions and get right to the root of the matter, I'm happy to do that. Unfortunately, I do have a hard stop at 9:20, so we've got 12 or 13 minutes to work with here, and I'm happy to proceed however is helpful for the group.
This is Haley with the Center for Evidence-Based Policy. I think that, thank you so much, Travis. To set the stage and kind of just put it in work group terms, how we've been speaking about this program, just for everyone, a quick summary. Utah is one of those programs that has an emergency access piece where they do allow for the emergency supply of insulin, but also what Travis is here about is the long-term insulin program, which offers the general public the ability to enroll in the public employee health plan and access the insulin benefit at a lower price because there's net of rebates. So that is kind of why we invited Travis, because that was a strategy that we've looked at. If there's any work group members that would like to jump in with a question, I would invite you to do that at this time, or we have prepared a couple for Travis that I can start with, and then feel free to jump in as people would like. I can't see if anyone has their hand raised, so please jump in if you have questions, but I guess we'll start with just one. Travis, could you speak to the policy design process in Utah as far as the different options they were considering as a way to provide affordable access to insulin, and why this specific one was chosen?
Yeah, this is Travis. A little background. Ultimately, the legislation sponsor, Representative Thurston, is better suited to speak to background. The piece that I'm familiar with is that Representative Thurston had asked us on a number of occasions, predating the passage of the legislation, if there was a way to get the post-rebate price of insulin, to make that price available for the public. And it certainly took us a little time to figure out how we might do it within our system. I suspect, although I don't have firsthand knowledge, that he was having similar conversations with other divisions. Ultimately, we found that one, PHP had figured out how to do it, and two, we were able to stand it up very quickly. And so, at least from my limited view, I think that part of the reason we got to where we are was that we'd identified a way forward, and it was a way that we could stand up within a matter of weeks, and not have to wait for either concessions from the manufacturers or concessions from another third party. We controlled all of the levers and were able to make it work.
Great, thank you, Travis. I thought I saw a hand. Did someone?
And Haley, there's also a question in the, so Lugina, see your hand up, and see that Kevin's question is also here. And Kevin's question is really about utilization, that Minnesota's had access about 1,000 times in the first year. Can you give us some volume of what sort of uptake you've had in Utah?
Sure. This is Travis again. We have, and I'll apologize, I'm traveling, so I don't have access to my computer. I'll get you the most recent numbers. I'll email them off. We fill approximately 90 prescriptions a month within the program, and so the volume is less than we anticipated. We've speculated that some of the reasons that this is less is that one, this program got started as the pandemic was getting going, and two, as a consequence of the pandemic and high costs, the manufacturer has been offering insulin at reduced prices for individuals who apply through their programs. And so we suspect that there's still significant volume going through the manufacturer programs. That's one of the reasons we see less in this program.
Hi, Travis. Hi, Travis. This is Legina. I'm with PCMA, or representative of the PBM industry. I just wanted to see if I could, if you could clarify for us the, because we're looking at the Utah program two ways, one for the emergency supply, but also a long-term solution for uninsured and underinsured. So I just wanted I want to confirm that if somebody doesn't have insurance, they have access to the post rebate amount from the PEHP program. But how is that administered? If I'm an uninsured person in Utah, do I go to the PEHP website in order to access or enroll, or how is that managed?
Oh, that's a very good question. This is Travis again. We've created a separate website. Ultimately, this is the state's program. It's not PHP administers it, but it's ultimately the state's program. And so we've designed it in a way that we hope it looks like the state and not like us. In order to make the post rebate price work, the member does have to come through. We have to enroll them, and so we've created a separate plan. Or a separate group is a better way to put that. The only benefit available within the group is insulin, and it is for the post rebate price plus an administrative fee. We use that administrative fee to fund the time value of money between the time we settle the claim or reconcile the claim, and we collect the rebate. So we do enroll members who are interested. If they're not enrolled, the program unfortunately won't work. But for anyone that's willing to take I think there are like 7 questions. If they take the time to complete the 7 questions, they'll receive an email with the information they need to process their next prescription, and they'll pay the post rebate price.
Okay. And can you could you just share with us a little bit, if somebody is on a commercial insurance plan and they want to use this process, is there a process, or they want to use the system, is there a process that allows that to occur? Or is it just uninsured and underinsured?
It's available to anyone. One of the cautions we'll throw out, all of you are involved in government relations in some form. A fiscal note on this bill is something that would have made it really tough to pass. One of the hard lessons, we learned it very quickly, but one of the hard lessons was to put limitations on the program so that this program always pays as the primary or as the first payer, and never pays as a secondary or tertiary payer. This is not insurance, it's only the post rebate price of insulin. And so by doing that, you limit the opportunity that somebody uses, say their primary insurance, and then uses this as a secondary benefit, and that functions as insurance instead of as a means to pass on lower priced insulin.
Okay, thank you.
Thanks for those great questions, Legina. There's one in the chat, or a couple for Travis. Do you think that the lack of full utilization is from a lack of education amongst consumers or providers, or both? Is there a group that works to reach the uninsured who don't have access to a website? And what does full utilization look like?
That's a very good question. This is Travis again. I think that both knowledge within the public and within the provider community, or more correctly, the lack of knowledge by those groups, is a contributor to lower utilization. One of our experience was that we worked with the Diabetes Association in Utah, who was very helpful in getting the message out. We've also worked with the Pharmacy Association. If we had it to do again, we would spend more time with those groups and trying to get the message out. We'd also spend some time with the Medical Association and trying to get that word out. By way of volume, we had some initial estimates, and it's now been enough years that I don't recall what they were. But we'd done some estimates based on the estimated number of diabetics in the community and the estimated uninsured rate and what we thought was going to come through. If I can find those, I'll share them with you, but I don't know, they're estimates. I don't know that they're terribly helpful at this point.
Great, thank you. I think we have time for one other question. Lita, I see your hand up.
Thanks. This is Lita Vasquez. Travis, how do you keep the program from being misused? In your 7 questions on the website, does somebody have to prove that they have a prescription for insulin, or can people start, filling out the questionnaire and getting the free insulin for a friend or family member?
Ultimately, we've, and the intent of the legislation, at least in our conversations with the representative, we're not aware that anyone's abusing insulin. We certainly understand that there can be financial abuses in secondary selling or moving to other locations. To date, we've not seen any of that. As we look at claims volume and number of units per claim, these are folks that are buying 1 or 2 units at a time, and not large quantities. The other thing that I will point out, the state of Utah in general, this is just a principle statement, uses an attestation very regularly, not only within this program, but within a number of other programs. For instance, if I go to have my driver's license renewed, I'm going to attest that I've satisfied all of the standards, and so that's one of the principles that the state has used in trying to reduce the burden of managing multiple programs. We ask people to attest. Ultimately, if there's a problem, the state's happy to pursue folks who have attested and then they've lied about the attestation. Maybe that's the fast way to say that.
Travis, thank you so much. I know you had a hard stop at 9:20. We really appreciate your time. We'll probably continue to have the conversation and may have a couple follow-up questions for you. But again, for you to take time out of your day, and I'm sure it's a busy day today, please know we are very grateful for your time today.
Well, you're very welcome. It's fantastic to talk to you. I'm happy to correspond by email if it's helpful.
Very good. Thanks so much.
Thanks, everybody. Bye-bye.
Bye-bye. And for the transcriber, I should have said this is Mary. But Lori, it looked like your hand was up. Did you want to go ahead and share what your question would have been so we can capture that and forward it on to Travis?
Yes, this is Lori Evans. You guys might already know this information, but is the insulin that's offered through Utah, and I didn't know how to put this in my question, is it top rated insulin? Like, is it insulin that I get through my employer, or is it the second rate insulin that they offer at Walmart?
Lori,
Sorry, just to clarify, those are analog insulins versus regular insulin. I'm sorry.
This is Haley. That is on their website. So while the meeting goes on, I can take a look and put it in the chat for you. It's with the certain manufacturers that they had existing deals with at the state. Travis told me in our pre-conversation, so I can get that information off the website and put it in the chat in a few minutes.
Thank you so much. I appreciate it.
Great. Thanks, Lori. Thanks, Haley. Jennifer, I see your hands up.
Yes. I had the question of, he mentioned a fee, and I just am curious how much the fee is and how often that would need to be paid for using the program.
This is Haley. That is another, they have an infographic with the average cost per, I think, type of insulin. That's also on their website. So let me just share the URL quickly, and then we can get that information. There is an average cost that they've estimated. Does that answer your question?
Yeah, that would be great. Thanks so much, Haley. We'll look at the URL, and Jennifer, if we still have questions, we can certainly circle back to that. Great. Any other follow-up on our the information shared by Travis? Okay, great. Well, let's move ahead to the state comparison of policy options for short-term emergency supply. And Haley, I think I'm turning this back over to you.
Yes, and I am going to share my screen.
Hey, Haley, this is Mike. Can I just interject something quickly? Haley, thanks for helping coordinate and getting Utah on the phone. I just want work group members to know that there was also outreach to Maine and Minnesota, but there has been some turnover just at the kind of the program level. So we weren't able to get folks on, but we still have kind of the ability to kind of ask some questions. But the folks who were responsible for implementing a lot of those programs aren't around. So that was kind of a challenge that we had today, trying to get it. The goal was to kind of have a panel discussion with some states. We were able to get Utah, but if there's any other specifics around Maine or Minnesota, we can certainly do some follow-up with them. But I just wanted to make that note. Thanks, Haley.
Yeah, thanks, Mike. So the next part of our meeting is going to focus on the short-term policy grid. This is something that was suggested during our last work group meeting as a way to kind of put the summary that we did of these different emergency options into an easy to read grid with some of the important elements that were identified during that meeting. And so we will go through this first table. Has kind of a description, definitions of each of the elements. The second table is just a high level checklist for referencing. And then we'll move into what we have drafted as a potential Washington policy based on our conversations in the work group. And that will end up with some poll everywhere questions that we'll ask everyone to participate in, so we can kind of get gauge the work group's feedback on the short-term solutions. So we'll go through these three tables. And then later on in the meeting, after a little break and some new information, we'll do the same thing for long term. So just wanted to lay the land for everyone. I'm not going to go, or I can go row by row, but it's a lot of information. And I think the point of the grid was to kind of put it in an easy to read, easy to reference table. But just to highlight, we have included the 4 programs, Maine and Minnesota, which are very similar. Ohio, which is a House bill that was not specific to insulin, but just emergency refills for all non-controlled drugs, and then the Utah pharmacy policy amendments. So I just want to highlight for Utah, this is not the program that we were just talking about, but rather that program allowed for, this is an updated statute to allow pharmacists to dispense emergency supplies of insulin. So it's just, this table will be just short-term emergency supplies. And the summary is that Maine and Minnesota both offer 30-day emergency supplies and require the manufacturers to reimburse for that emergency supply. I would say that is the distinguishing feature of those two policies versus Ohio and Utah. They do not require manufacturer reimbursement. It is just through the normal process, but Maine and Minnesota include manufacturers. We've included some information about specific to insulin, the emergency prescription authorization. This was talked about in the last work group, and you'll see that all of the legislation is linked, and anything that we reference is also linked, so you can check out for more information. We'll get into I think an important piece is the application part of this, which we'll get into just a little bit. Eligibility criteria. So for Ohio and Utah, there is not specific eligibility requirements, but for Maine and Minnesota, the main ones are that they must be a resident, not enrolled in a health plan that limits cost sharing to $75 or less. Household incomes are less than 400% FPL. And then there's some criteria for if you're part on Medicare and how much you have spent on prescription drugs. So you'll see that these two do require proof of Minnesota residence in the form of an ID. And that is something that the work group we've talked about. That's a criteria that has been highlighted as maybe restrictive. All of these programs offer at least 30 days. So the first 3 is 30 days access once in a 12, or sorry, first 2 for Maine and Minnesota, once in a 12-month period, 30-day supply. For Ohio, it's also a 30-day supply at first, but they can access it multiple times in a 12-month period with 7-day supply in the next 2 points of access. And then for Utah, which runs a little bit differently, it's based on the exhausted prescription and there's criteria for that, but it can be filled in an amount up to 60 days. So those are the differences. For administrative funding, this is really for state resources to run the program. An important highlight for the main program is that they levy a $75,000 licensing fee annually on the manufacturers. And they also allocated 1 state FTE to manage the program. And then for Minnesota, they do not assess that $75,000 licensing fee, but they did appropriate state funding for the program. The big chunk at the beginning is for a peer navigation program, the training of that, the curriculum, the certification, and then accessing it, and then that dwindles down as it's like considered a one-time investment. And then Ohio and Utah had no appropriations clauses attached to their bills. Similarly, Maine and Minnesota, for the co-payment instructions, are grouped together that they may charge $35 to cover the dispensing fee. Ohio and Utah did not have any language around that. For the application process, so for Maine and Minnesota, since it is a program that is involves a manufacturer and there's an application online and at healthcare settings, so it's on the patient to fill out the application and prove that they are eligible versus with the criteria we went over earlier, and then they bring that to the pharmacy, and then it's also on the pharmacy to determine eligibility at that point that they are trying to access the emergency supply. There's no application involved in Ohio and Utah's programs for the emergency supply part only. And then for reimbursement for Ohio and Utah, that's standard, but for the Maine and Minnesota programs, the pharmacy submits a claim to the manufacturer, and the manufacturer is responsible for either backfilling with supply or in the way of an electronic claim and reimbursing them at their acquisition cost for that. Moving on, another important consideration that was brought up in our last work group meeting was whether or not educational materials were provided on the patient assistance programs. And so in Minnesota, the pharmacy must provide an information sheet with how to access the health insurance consumer assistance program. Similarly, for Maine, they are required to have an information sheet, and then they also were providing that extra service of trained navigators. So the information sheet includes contact information for those as well, and also the information on applying to the long-term assistance program, which we'll talk about later in the meeting. The work group was also considering whether or not it should be a requirement for the pharmacy to report to the original prescriber. And so we've listed the policies for this. 3 of them require notifying. Ohio requires keeping a record, and they have different time spans for that. And then we also just listed the general statewide emergency prescription authority just for reference as kind of frame or setting the policy specific to insulin. And then for the last one, we've just noted any other specific identifying characteristics of the program. So in Maine, they did include some language about allowing pharmacists to dispense diabetic supplies along with insulin, which has been brought up in the work group several times. And then for Utah, same thing. It allows pharmacists to dispense supplies along with insulin. That is the definitions. I see Lugina raised her hand. If you want to ask a question, go ahead.
Hi, Haley. This is Lugina from PCMA. I'm also a pharmacist. So I wanted to ask a question about the difference between the Maine and Minnesota program and then the Ohio-Utah columns. I just want to make sure I understand correctly, because as a pharmacist, each state allows us as pharmacists to dispense, generally allows us to dispense an emergency supply. Say if it's Friday night or it's a long holiday weekend and the physician is not accessible or the provider is not accessible, but the patient needs a refill of their medication. Generally, there's some allowances made so that pharmacists can take care of patients during that, emergent timeframe, so to speak. So I just want to me, when I'm reading the Ohio and Utah columns, to me, that seems more like allowances for pharmacists to engage in that emergency dispensing, like whenever a prescription's out of refills or the provider's not accessible, to allow us to dispense a product. But it doesn't necessarily mean that product is being provided at a lower cost or no cost or whatever the case may be, as opposed to Maine and Minnesota, which truly sounds like a program where there is some sort of provision of the product and an offset of the cost for that patient. Is that an accurate representation of kind of the way these two kind of columns, or these 4 columns, kind of mesh out generally?
Yes, Lugina, I think that's a great way to summarize it. I think we were thinking of a continuum of policy options with different intents, I guess. So yes, I think that's a perfectly accurate way to summarize that.
And I mean, I do like the way that you guys, how you have like, there's a table for short term and then there's another table for long term. Because I think that, like, for example, a Utah program is it's a more program, kind of like Maine and Minnesota for that, for the, the using their PEHP post rebate thing. That's where they're actually, sharing some cost savings. So, but I just want to make sure I had it kind of right in my head as far as how I was thinking about this short-term table.
Yes, I think you are definitely thinking about it correctly. And thanks for doing that summary. I think it's very helpful for everyone. Did you have any other questions, Lugina?
Oh, I'm sorry.
No, great, thank you. I think I saw Jenny and Jennifer had a question. Jenny, there you are.
Yeah, I just wanted to highlight, thank you for calling that out. We talked about this briefly on a previous call, and I think about it as payment versus scope. Pharmacists in Washington have the ability to authorize a 1-month emergency prescription for patients if they're out of refills, if they can, and they can help to facilitate that. There's slightly different rules if there is a declaration of emergency where patients can just walk in with the kind of their prescription vial or their labeled vial to be able to get refills. So in Washington, we've covered and already taken care of that scope issue around pharmacist refills. So yay, we gotta check that box done. And so then it's really on the payment side that we need to kind of address and we get to focus on. So just to check that box for all of us. We did that through our rules rewrite a couple of years ago. Thank you.
Great, thank you, Jenny. Jennifer, do you have a question?
I just wanted to comment, because I'm looking at the, I'm not sure what our general statewide emergency plan is for just all medications here in Washington, but I just know that I've experienced this years ago, and I remember talking to a patient or a pharmacist about a patient over the phone, that if someone is using pens, that the pharmacy does not want to break open a box and fill a partial box of pens, because they come in boxes of 5 pens. And so I just think that that might be an issue, especially if it's like only a 30-day or if it's a 3-day supply. I see one of these is 3 days, or if it's a week, or depending on that, like it's not likely it's not going to be a full box for everybody. And so I just wanted to point that out.
Thank you. That's an important consideration. I think that's a good thought to keep in mind when we go to the potential Washington policy. Just make sure that we're thinking about whether or not that situation could occur and how to best handle. So thanks, Jennifer. Are there any other questions on the first table, short-term supply policy options? Anything else you'd like to see in terms of the elements, or any other questions? I'm not seeing any, but feel free to jump in if you do have some. Moving on to this table 2, which is the same information as the table above. It's just in a checklist format for easy reference. So it is the same information. There's not anything new to go over, just kind of as a comparison to the different options. And I know I blew through that first table. I was a little concerned with timing, and now I've realized that we have more. So just this table 2 is summary information of the first one. I'm not seeing any questions, so I'll keep moving on, but feel free to interrupt. So then table 3 is our potential Washington emergency supply policy recommendations. We went through the feedback from all of the work group meetings, the surveys, and then the policy options we presented, and kind of tried to summarize what a potential policy might look like given all those pieces of feedback and make it representative of what the work group has expressed. So when we do have some important considerations in this table that might warrant some discussion. So if you're seeing something that you are immediately have a reaction to, feel free to bring that up, and we want to talk through those. So we'll go through this table, and then we will move on to having a poll everywhere question, so you can quantify your response and support for each of these different elements. So that's kind of what the next part of the meeting will go over. So, oh, yep, Kevin.
Sorry, excuse me. This is Kevin Wren. I just wanted to quickly highlight the co-payment cost. It's $15. Is that what that says for consumers?
Yes, that is what it says, and that was based on some feedback. So that's our recommendation as of right now.
Okay.
For this table.
And I just want to make a quick point that we can make that 0 by like just billing the government $15,000. I mean, this program was used like 1,000 times by Utah, 1,000 times by Minnesota. So I think we should work to make that co-payment as little as possible and those barriers to entry as small as possible.
Okay, great. Yeah, thanks, Kevin. So we'll have a question specifically on that too for poll everywhere, how strongly you support each of these elements. So I think that's great, but thank you for that feedback. We'll make a note. So for the summary of the policy, this would be a once yearly 30-day emergency supply of insulin. And for table setting, that's because that's what this work group was directed to discuss, is a 30-day supply. Other policies have made that once yearly 30 days. So that's what we've had in this, that's what we're going with for this potential Washington policy. We have noted significant work group feedback to make it more, but that would be the summary. Emergency prescription authority, which would be specific to insulin, would be similar to Maine and Minnesota's program, where it would require a completed application, and then the pharmacist could dispense the emergency refill of insulin along with related devices and supplies, which was another piece of important feedback from the work group. This amount supplied is where we note that there was significant feedback from the work group that the emergency supply should be 90 days rather than 30 days, and they should be allowed to access the emergency supply more than once in a 12-month period. And this is where we wanted to kind of have a discussion with everyone about the specifics about that. Emergency supply should be 90 days. Does that mean 90 days straight, or does that mean people would prefer 30 days and be allowed to access it 3 times throughout a 12-month period? That does seem to be a distinction that we need to make and we have not considered yet. So would love to hear some feedback now. The poll everywhere questions are just a Likert scale 1 to 5. So there's not room to provide like any other feedback related to this question. So if you have feedback about 90 days, it should be a one-time or multiple times in 12 months. This would be a great time to share.
This is Kevin Wren. I think it should be one 90-day supply, and then you can utilize that as many times as possible. I think you shouldn't make it complicated and having people to break up their 3-month supply into different chunks. I don't know if that makes sense. Especially when you're struggling to afford insulin, like we just have to make this program as easy to access as possible. And I think overcomplicating it with like what months you choose is unnecessary. If we could just get our 90-day supply of insulin, that's all we really need, and kind of remove those barriers and make it as uncomplicated as possible. And being able to utilize it more than once a year. I mean, so many things can happen to your insulin. We've talked about it over again on this work group call. So, I mean, there's so many things that can happen to your insulin in 90 days. It can take a while to get coverage, see a provider, get a prescription. So I really think this 90-day supply piece is crucial. And I think it should be one 90-day supply that you can access numerous times.
Okay, thanks, Kevin. Lori, I see.
So
your hand
I'm
in.
sorry, before we
Mary,
move
go
on,
ahead.
Kevin, I just want to make sure I'm clear on that suggestion. So what you're asking for is 90-day supplies anytime that 90-day supply is needed.
Correct.
Gotcha. And
Thank
just,
you.
you know, and it's not that we haven't heard the input around the 90 days, but just, and Haley, I apologize if you already said this, but the legislation specifically calls out for this group to be reviewing this policy, a once yearly 30-day emergency supply. So we'll certainly add any comments around it wanting to, you know, indication from the work group to expand that. But I think, you know, in order to comply with the legislation, we do have to answer this question specifically.
Yeah, I completely understand. Thank you.
Great, thank you.
How about we go to Lori and then Jenny?
Okay, this is Lori Evans. I'm an insulin user, and I love Kevin's idea, what he just spoke about. But I understand that that's unlikely to be reality. So as an insulin user who on occasion struggles with finances, I would personally like to see a 30-day supply available to me multiple times a year. So not just a 90-day supply one time per year.
Yeah, I was saying 90-day supply multiple times a year. So, I mean, either way,
Yeah.
30 days or 90 days, being able to access it multiple times a year, I think is crucial because, I mean, if something goes wrong within that 30 days, you're kind of screwed for the next 30 days. So
I understand that.
yeah,
Okay.
thank you.
But I personally would like to see a 30-day supply option multiple times a year. And if something happens to my insulin within that 30 days, then I can reapply the following 30 days.
Okay. So
Thank you.
what I'm hearing is a 30-day option and a 90-day option, but being able to access it multiple times a year.
Lori is suggesting a 30-day supply multiple times a year.
Got it. Okay. Yes.
Thank
And Kevin is 90-day multiple times a year.
Correct. Thank you.
All right. Okay, great. Okay, great. Thank you both. Jenny, did you have a question? I think I lost you in my video. Okay, we'll keep moving on, but feel free to jump in if you have any questions.
This is Lita.
Oh,
Jenny's on mute. She was talking, but on mute.
Oh, okay.
Yes, I was double muted. Thank you. So I do agree with Lori. I think 30-day supply once yearly as a pharmacist absolutely gives a patient an option to try to find care, but 30-day supply multiple times a year, I think is a better option. I don't know if we want to cap it based on the cost or if we want to have something in the application that allows for a specific time frame of concurrent refills. I think as a pharmacist, we could work under a CDTA and actually prescribe the insulin rather than based on criteria, rather than just continuing to do a 1 month supply so that patient can feel a little more secure, not feel like they have to get a 90-day supply. As we know, insulin storage conditions can be very tricky. If somebody is houseless, giving them a 90-day supply is potentially wasting additional.
I'm sorry,
making
I completely disagree.
Okay.
I get 90-day supplies now through my pharmacy, and it's like I can elect whether to get 90 or 30 days. So it's really should be within the patient's right. I don't think it should be restricted by the pharmacist.
This is Lita. Let's let Jenny finish speaking before we comment.
No, that's fair. I really appreciate the perspective for sure. And would definitely defer to the patient for their ability to store the insulin. So that's a very good point. Thank you, Kevin.
Jenny, I have a follow-up, just real quick question. Is there anything in the policy, the emergency supply policies that we've gone over that would restrict that pharmacist's ability to prescribe? Is there anything that any policy element we need to adjust to allow for that, or could that exist in the structures we presented? Oh, I think you might be muted again.
I'm on mute again. Let me look over that. I have a problem with my mute button, and I will consider that when I read it over again, and I'll let you know.
Okay, yes, please let us know. I think that's a great point and not something I considered before. So thank you for sharing. Jennifer, did you have a question?
Yeah, I wanted to just contribute my 2 cents on the 90 versus 30 versus multiple times. In a perfect world, I would say all of them. If we had to choose, my preference would be, because maybe we're not going to get multiple times. So if we can't get multiple times, then I definitely prefer the 90-day over the 30-day. But I feel indifferent to if we were able to do 90 days all at once versus like 30 multiple times. Like I don't know. Just if we have to do only one, then of course the 90-day would be better than the 30-day.
Great, thank you, Jennifer. Okay. William and then Sherry.
This is William, thank you. I wanted to contribute to the discussion on the pharmacist CDTA process, which we're going to look into, but in terms of communicating the decision-making process on the 30-day supply and assisting the patient. As you know, I work in corrections, and our patients upon reentry sometimes are unhoused and don't have the ability to store medications. So the patients can communicate with the pharmacists, and I believe that is what the previous pharmacist, Jenny, I think, was trying to indicate, that the pharmacist would be able to work with the individual patient and determine whether they needed it immediately the next month, or whether they couldn't maintain an amount greater than 30 days. And I just wanted to make sure that we keep that in mind. Not every patient is able to store 90 days of insulin. So we have to remember that we are working with unhoused or patients that are able to maintain insulin. So I just wanted to comment on that.
Thanks, William.
I just have another follow-up. I'm sorry.
Can we go to Sherry and then we'll go to Kevin, if that's okay?
Yeah.
Thank you. And so kind of somewhat related to what the previous speaker was just mentioning about unhoused people. As far as like the difference between allowing like, you know, a 30 or 90-day supply, I guess one of my questions too is, as far as if it is a 30-day supply and people would need to reapply, is that, are they going to be able to reapply? Is that going to be an easy process for someone who is unhoused? Would it be like a paper application, or is this something they're expected to do online? Because if it is, obviously, I think that's a little more complicated for people who are unhoused. And then the other question, since I haven't been involved in the work group discussions previous to this, I don't know if this has come up, but I didn't know if there had been any discussion about, I know we're also going to be looking at some long-term solution option. And has there been any thought about how those two may integrate with each other? So like at a certain point, if someone is needing to use emergency supply X amount of times, does it make more sense, you know, if there is this long-term solution, that they would be, you know, kind of directed towards that option?
Yeah, great questions, Jerry. I think your first question related to applying multiple times is a great one, and something we haven't seen in other state options that we went over, because they do restrict it to one time every 12 months. So I think that's important consideration that the work group will need to design a policy if we're going to do more than once yearly. Again, the legislative directive is to look at once yearly, but if we're going to include our feedback, that's an important consideration I don't think we've talked about. And related to your second point, I also agree that that's something that the work group would need to figure out. If we're doing more than once yearly, how does that interact with the long-term option? I think we've addressed it in the work group. One way that we've thought about it is by providing the information and educational materials that point to the long-term assistance. But in terms of logistics beyond that, we have not discussed that in the work group yet. So thank you so much for bringing that point up.
Yeah.
So I think it was Kevin and then back to Jenny.
Yeah, this is Kevin Wren. It seems like Ohio has the 60-day supply and they haven't run into any problems. I would maybe like, can we talk to them about why they chose to do 60 as opposed to 30? I mean, if they can do it, why can't we do it? I mean, if you have a problem with someone housing their insulin for 90 days, then you're going to have a problem with 60 days and 30 days. So like, I understand your reactions about unhoused people not being able to store their insulin, but I think this program is being utilized more than the unhoused. And while we should consider them, we should also consider the 1,000 people who use this program successfully in Minnesota and in Utah. Like, it's really frustrating to have these conversations again about 90 versus 60 versus 30, because we should be able to utilize it multiple times a year, and it should be, you know, as long as we need it.
Okay, thank you, Kevin. I think it was Jennifer, then Jenny, then Jennifer, and I will note, Amber, we got your feedback in the chat too, so thank you for sharing. So Jenny, then Jennifer.
Hi there. I wanted to move off the 30-90 day supply, if it's okay. I had two questions for this. First of all, $15 copay, is that per 30-day supply? What does that look like? It's not, so co-payment instructions, the pharmacy should be made whole, including dispensing fees through co-payment of $15. I think as we identify what our day supply is, we should be identifying if it's $15 for a dispense or if it's $15 per a day supply. Typically we do per day supply, but and I think that's a little easier for the pharmacy applications to put forward. And then the second question I would have is in other areas, when I was reading over this, it looks like there was pharmacies that were registered as part of this process or part of this short-term program. And I'm wondering if we're considering something similar within this program.
I think that's a great question. Ryan, were you going to, I'm not sure about the registration for pharmacies in the other state programs. That have to look into that unless there's someone on the line who feels that they can answer that question.
Hi, this is Ryan. I may be able to answer that. So I think in terms of the pharmacies that are registered, it's who's in a network. So like for the Utah program, it's through their public employees network. And so if the pharmacies are contracted with that plan, then they're able to adjudicate the claims and get that process where they have the right price at that time. Because if they're not contracted, they're not going to know what that rebated price is. In terms of the copayment, that $15 was for the dispensing fee. So it's not tied to the amount of drug like a traditional copay is, where a copay is typically at a 30-day supply. That's because the plan is paying for some amount of drug and then the member is paying for some amount of drug. And if you do a 90-day supply, that's 3 times the amount of drug. And that's, where that member payment is. Because this draft policy is around the manufacturers paying for the supply of drug, that $15 dispensing fee should be the same regardless of whether it's a 30 or a 90-day supply, just given that it's only for that one-time dispensing fee.
Thanks,
Thank
Ryan.
you so much
That's
for that
very-
clarification. Sorry. Yeah, thank you. Okay, Jennifer.
Yeah, thank you. This is Jennifer. I am, since we were discussing houselessness, I wanted to reiterate that $15 may be too much for these individuals. And then on another note, I wanted to just point out, I think some of the frustration that my fellow diabetics feel comes from the fact that diabetes is a natural variation of the human condition, is just the way that we are, and that our bodies, diabetic bodies, have been over medicalized, that make it so that our systems monitor and gatekeep us for accessing our human needs. And then I wanted to read Amber Markland's comment, just because I want to make sure that it gets into the transcript here. Amber wrote, just to add to what Kevin just mentioned about, it should be up to the patient whether it's 30 or 90-day supply, and not up to the pharmacist. We live in a world where things like insulin should be free medication for those that cannot live without it. There are gatekeepers put in place to ensure that this does not happen, and why we are all here. For those of us that depend on this drug to live, this can be a very triggering and frustrating conversation. And I want to add to that. So please forgive us that we probably are emotional, because this is a very it's a life or death for us. So thank you.
Yeah, thank you, Jennifer, and thank you, Amber, for sharing. Okay, that was a great discussion on the amount supplied. I'm going to continue moving through the table, and feel free to raise your hand if you have any questions or anything to add. So moving on to the funding source, like Ryan just mentioned, this would be similar to the Maine and Minnesota program that requires reimbursement by manufacturers. And another funding idea that came up through the work group is the consideration of state FTE to administer the program, and to help ensure patients, pharmacies, providers, and manufacturers are aware and able to resolve any issues. So that is something that we heard from the work group and included. We did not discuss many specifics around the number of FTE or what the specific job would be, but that we wanted to include that in the funding source considerations. And then moving on to co-payment, which Ryan also just laid out for us, that $15 would be to cover the dispensing fee. The manufacturers would be responsible for either sending the replacement supply, or by filling the electronic claim that the provider or the pharmacy would submit to them. For eligibility criteria, the recommendation is to require state residency, which would mean providing a Washington address on an application form. It would not require the state ID, which is the next point. If you were, we had heard from the work group that requiring state ID would limit access of people who are undocumented, homeless, or visiting Washington. And so the recommendation would just be to require providing an address, a Washington state address.
I'm sorry, just a quick clarifying question. So we're trying to get to help the unhoused, but they need an address? Like, how would that work if you're homeless?
Yeah,
and you need to provide an address.
The ArrayRx, thank you, Kevin. The ArrayRx eligibility criteria is this right now. And I think that people are able to put shelter addresses if they're unhoused as their physical address. Lita, I would invite Lita to share more about how that works operationally. But Kevin, did you have a follow-up?
No, that was perfect. Thank you.
Okay, great. Yes, so that's eligibility criteria. The application process would be similar to Maine and Minnesota in the sense that there is one and the patient would bring that into the pharmacy. But unlike those, the recommendation would be that the pharmacy would not be required to maintain additional copies of the application, which is what other programs require. And another work group recommendation was to ensure that the registration system be standard and easy to use. So the other programs provide applications online as well as in healthcare facilities. So I think that was an earlier question about how to access them. There are paper copies in the community and also online. Reimbursement process. So we've gone over this several times, but the pharmacy would be supported by the manufacturer with replacing the stock or reimbursement from a claim. The majority of work group members supported requiring manufacturers to reimburse supplies, but some thought that pharmacies should be able to choose their preferred reimbursement process. That's a note that we've included. And then another recommendation was to put a time limit on the amount of time that manufacturers have to complete that reimbursement so that pharmacies aren't left waiting. And the example was 10 days. And then the last two elements of the policy would be providing educational material on how to access the emergency, or to everyone accessing emergency supply, and should include other services or health insurance options that the state can provide to patients. And then the last element would be to not mandate prescriber reporting requirements due to the administrative burden of that, which would be a break from the other emergency supply programs around the country. They do require that reporting. So I'm going to stop sharing, or let's pause and see if there's any questions related to the following elements that we just went over. If not, we do have poll everywhere questions where you can submit your support for each of these elements. But are there any questions right now? Great, okay. Let me stop sharing. Mike, I saw you come off mute, I think. Did you have anything to add?
I did. I'm ready to step in if you want me to help with the, you've just been going 10 million miles an hour. It's amazing. So I wanted just to give a huge shout out to Haley. I mean, she's become kind of this state insulin expert, and I don't think she had that understanding at the beginning of this project. So huge kudos to her. So I want to set things up as we kind of go through this, because we are going to be asking your feedback on each one of those elements. So we've done this before. If you guys have a chance to kind of get signed up with Poll Everywhere, the link is there. Can we put that in the chat as well, Ronnie or Haley? So you can just link that. It's already there. Ronnie's ahead of me already. So it's already there, and you can do it on your smartphone. So you should be able to see this, and it's your choice if you want to be anonymous or fill in your name, totally up to you. But I'll give everybody just a second to complete that. And as Haley mentioned, we've set everything up right now on a scale of 1 to 5, 5 being strongly support. But I also want to make sure that we capture some of this robust discussion that's been going on, because sometimes it's nice to be able to quantify something, but we don't want to lose all of this additional information. So I want to make sure that we're going to use the chat in a way that if you have additional thoughts or comments, we can do that. So why don't we, so if you go back to, if we think about that grid that Haley just walked us through, kind of had all of those elements, we're going to take each one step by step and have you do this evaluation of your own scoring really on this Likert scale of 1 to 5. But I also want you to have the ability to add a certain comment, right, or a thought that may not be captured in an actual just a number. So if we can go to the next slide is the first there. So I'm going to give you an example. So you guys are going to rate this right on a scale of 1 to 5. So as Haley kind of talked about, the Emergency Prescription Authority, upon receipt of completed and signed application, pharmacists may dispense emergency refills of insulin and associated insulin-related devices and supplies. So you guys are going to then, again, already starting to fill that out on a scale of 1 to 5. However, if there are additional thoughts, comments you want to make, what I am going to recommend, I'm going to do a quick test here. So in the chat, I just put like an example. So I'd love for you guys, as we go through each element, if you have a thought, if you could tag your thought to this specific element. So for example, I just put in emergency prescription authority, X, ... Whatever you want to kind of talk about, we just want to make sure your comment is linked to this specific element. So we can go back and say, okay, here's how everybody kind of quantified it. And then here are the additional comments that we would be able to bring into that. So again, you think about all the months of work that we've done with you guys have really started to winnow this down, and you're starting to kind of get this set of kind of core policy options. And now this is even some further refinement that we'll have at the end of this meeting. And then that starts to help shape kind of the final report that will come out of this. I'm going to pause there. Any other thoughts, comments as I kind of look into the chat, if there's any other comments? I just saw something come in from Jennifer Perkins. Thank you. Jennifer, I just want to make sure that goes, I'm going to forward that on. I just want to make sure that goes to everybody as well. You don't need to directly. So Jennifer, you talked about expand emergency prescription authority, do not add barriers for pharmacists such as a complicated form. So all great comments I'll put back into the chat. Okay, and I'll capture that. Awesome, thanks, Jennifer. Okay. You guys have the routine. So just make sure that I don't think we've got the scale listed at the bottom, 1 to 5 on everyone, but everything is 1 to 5, 5 being strongly support for each one of these. Okay, Ronnie, let's go to the next one. So amount supplied. Emergency supply should be 90 days rather than 30. The one caveat I have is just knowing what Mary laid out before was that the legislation was clear that this work group was going to be looking at the 30-day supply. That doesn't mean that you can't have a recommendation that would go beyond that. Just want to make sure we're still meeting that intent.
And 5 is strongly agree and 1 is disagree.
Strongly disagree. That's right. Thanks, Jenny.
Okay.
And William, I saw your comments in the chat. Thank you. So again, if you have thoughts, comments on this one in the chat, you can put amount supplied, colon, and then whatever you've got. Yep. Thanks, Sherry. Excellent. And if there are other kind of thoughts, comments, any other group discussion, if you have something in the chat that you feel is kind of warrants further discussion, we're happy to have that as well. Want to make sure you guys feel heard and we can get all of this stuff out here now. 3, 2, 1. Thanks, Legina. I'm just checking your comment too. Need to ensure alignment between the Board of Pharmacy rules. I recall Jenny stating the emergency dispensing is limited to 1 30-day supply right now. And Jenny, that's what you had mentioned earlier, correct?
Yes. And CDTA is a collaborative drug therapy agreement. They do not need a collaborative drug therapy agreement, which is how many pharmacists prescribe insulin. We just have in our rules the ability for a pharmacist to refill a medication that the patient has, as long as they've been to that pharmacy or the pharmacy can transfer the prescription or get some verification that the patient is on it without any collaborative drug therapy agreement, prescriptive protocol, standing order. They are allowed to refill an emergency medication. There's more allowances and flexibility if there's a declared state of emergency that they just need then the prescription vial or something like that, a medication list or healthcare record that they can access. But if you're going, I know that there's still a gap there if the patient's moved and doesn't have an established pharmacy, but for the vast majority of our patients, we already have that ability in the state law.
Got it. Thanks, Jenny. Okay, Ronnie, yeah, let's lock that down. We'll go to the next. So again, amount supply. A patient should be allowed to access an emergency supply more than once in a 12-month period. So already had some good discussion on this morning. Great. Looks like there's some strong support for that. I'm checking for any comments here. Great. Give folks a few more seconds. Yeah, Sherry, you brought that up earlier. Thanks. So we'll talk about our long-term solution, but I like you bringing that point up around the bridge, right? From going from the short term to long term. So it's a good point. Okay. 3, 2, 1. Yeah, thanks, Ronnie. Let's lock that. So funding source, reimbursement by manufacturers as long as that covers pharmacy costs, including insulin and business and occupation tax, the gross receipts tax. And Jennifer, saw your comment in the chat as well. Thanks. Okay, waiting for any other changes here. Hold on a sec, Ronnie. I'm just making sure that everybody is in. Looks like folks are in lockstep here. Let's just see. Thanks. So a little bit more. All right, so really strong support there. And I would just also say if you are voting lower than the 5 and 3 or the 1, if you have other thoughts around what that reimbursement or that funding source could look like, I would encourage you to put that in the chat as well under funding source, just so we would have a better idea. Okay, Ronnie, let's lock that. Thanks. So another funding source question, appropriate state FTEs to administer a program and help ensure patients, pharmacies, providers, and manufacturers are aware and able to resolve any issues. Yeah, thanks, Jenny. That's come up in a number of our prior discussions as well, right? Just keeping this program simple and easy to use for everybody, patients and pharmacists. Okay, some strong support there as well. Great. Ronnie, let's lock that one down. We'll go to the next. Pharmacy should be made whole, including dispensing fee through a copayment of $15. Okay, a little different here.
I don't know what this question means. A pharmacy should be made whole. I don't get it.
Meaning cover the cost of dispensing.
Cover the cost,
including
right.
The vial, the labels, the processing fee, the B&O tax. So that's what that means.
Thank you.
And I think, as Kevin mentions, a co-payment would be the patient would pay it versus another method to reimburse pharmacies.
So I've got a few things coming in chat, and I'm going to back up. Hey, William, you had one under the prior one. I just want to make sure I capture that. You had manufacturer should be responsible unless pharmacy company has major deal with manufacturer already.
Well, I learned based on conversation earlier today that Walmart has a Walmart branded analog, and I don't want to go beyond discussing individual companies beyond that, but it appears that some major corporations have deals already with purchasing and dispensing insulins, and I would say that those deals should be considered when we are seeking funding. So I just want to make sure that we're not giving, we're looking at those companies that are already getting discounts and not reimbursing them more than they should be getting, or asking the manufacturer that's already inked a deal with that company more money when it's already discounted the pharmacy that they're selling it through. So it's essentially that I'm trying to.
Got it. Yep. Okay. Thanks, William. I'm just going through the rest of these chats. Lugina, you got your question answered on the business tax that would have included, correct?
I think, I mean, because when Jenny was just talking about this question, she did include the tax. Is that right, Jenny?
That was the intent here, I believe, that
Well,
again, pharmacy would be made whole from all of that.
Yeah, I can say that a pharmacy probably won't, the $15 will cover the cost of the pharmacy to dispense that product in general, but it may not cover the full B&O tax. The previous question did specifically call out the business and occupation tax. So the business and occupation tax is one of the major taxes in the state of Washington. They tax businesses, including pharmacies, on the their gross profits. That's challenging for pharmacies because that so much so much money passes through a pharmacy for medications. The pharmacy doesn't keep that money, which would be a net. It's that, let's say, $100 that the pharmacy purchases a medication for $90 to dispense to a patient. They get paid $100 by the insurance company for that, but then has to turn around and pay their wholesaler $90. So the pharmacy just gets $10 to cover the salaries and the labels and the software and the computers and the rent and all of that. The $10 would kind of be above those costs. Whatever's left over from that $10 would be their net, but they're actually taxed on the whole $100, even though that's not what they're keeping. And that's the challenge with some of this just pharmacy in general. And I'm not trying to nitpick the business of pharmacy, but that's kind of where the question is coming from in the background.
This is Ryan. Oh, go ahead, Mary.
No, go ahead, Ryan.
So this is Ryan from Healthcare Authority. So I think the reason that we included the B&O tax in the previous one around the manufacturer reimbursement is around how the manufacturers could reimburse it. So as Jenny had mentioned, the pharmacy may be buying this like $300 of insulin from a wholesaler. If the manufacturer were to only reimburse that $300 of the amount of the drug, it doesn't cover that B&O tax. And so if the manufacturers were to fully reimburse the pharmacy for that cost, they'd have to do the $300 plus that B&O tax that would be levied on that pharmacy, or they would have to then reimburse the actual insulin, so that way they're replenishing the stock. So I think that's why the B&O tax was considered in the previous one, because as Jenny mentioned, it's going to be around the cost that the pharmacy is purchasing the insulin from a wholesaler, rather than around this, which is the dispensing fee, which is, the services that a pharmacist is providing to the patient for their care.
Thanks, Ryan. Mary, did you have a comment? Mary, I'm guessing you may be checking time. I'm doing the same.
Right. Sorry. And also trying to figure out how to make sure I'm off mute. So no, Ryan covered it beautifully. Thank you.
Okay. Thanks.
And also checking time.
Yeah, I know. I'm checking time too. So we're gonna move through these next, and I am checking chat. So Kevin, I got yours on copayment. Sherry, sliding scale, great point. Kevin, you had other on the Utah, Minnesota example. And Jennifer, yours on just minimizing overall costs. Yep, got it. Thanks, guys. Okay, so we're going to keep going. We've got a break coming up that we want to get to. So eligibility criteria, you guys have touched on this already, but utilize ArrayRx current eligibility. All state residents qualify, no age or income restrictions, would not require ID or documentation of residence. All that is required is a Washington trust. For those people who are houseless, they could put down shelter or leave it blank.
And I'm sorry, it may be just me, but my content didn't move to that question.
It didn't. Huh. Everybody else have that problem? Mind?
Brian, I was able to go for it. Mary, are you able to refresh?
Yeah, sorry, it refreshed. Thank you.
You got it. Okay, another few seconds here. Yep, Ronnie, thanks. Let's lock that down. It's good. Support there. Simple application online if possible. Thanks, William. So application process, pharmacies should not be required to maintain copies of patient applications. Jennifer, thanks for that. Yep. Jenny, I just saw your comment on the waiving the dispensing fee. That's something we hadn't really discussed, but I like that. Be able to include that. Should not be required. Okay. I think we're good. Let's lock that one down. So good support there. We're going to go on to application process. Everything you guys have talked about. Registrations should be standard and easy to use. I think we could probably flip through this one pretty quickly. I'll give folks just another few seconds here. Sherry, I just saw yours. Yeah, it's a good comment. Consider whether how often people need to reapply. Ronnie, yeah, let's lock that one down. Thanks. Okay, so reimbursement. Pharmacies need to be supported by the manufacturer through replacement stock or reimbursement from manufacturer or through state funding. Great. A few more seconds there. Support. Okay, Ronnie, let's lock that one down. We got to keep moving here. Thanks, guys. Allow pharmacies to choose preferred reimbursement process. Jenny, this kind of hit probably a little bit on what you were talking about. Great. Good support there. And yep, Ronnie, let's lock that one down. Last one on reimbursement. If manufacturers are to reimburse patients, policy should make sure reimbursement is timely, e.g. within 10 days.
Hi, this is Ryan. Is it supposed to be reimburse pharmacies or patients?
Pharmacies. Yeah, I just saw that too, Ryan. That should be pharmacies.
Great. Thanks for the clarification.
Yep, thanks. Few more seconds there. Great. Good support. Yep. Thanks, Ronnie. We'll lock that one down. Educational materials provided. Educational materials should be provided to all patients accessing emergency supply and should include information on wraparound services and other health insurance options or state programs. Few more seconds here. We just have one more. And thank you guys for bearing with us, but this really helps kind of put some clarity on how we can kind of start to craft this overarching policy proposal. Okay, Ronnie, great. Why don't we lock that one down? We'll go to our last one. Prescribing reporting requirement. No mandated prescriber reporting requirements due to burden to pharmacies and unclear value. And if you are a C, and if you're not in full agreement with that, if you have other thoughts on what that reporting, requirement or reporting should look like, you can certainly put that in the chat as well. It goes a few seconds. Okay, Ronnie would lock that one down. And I think, Ronnie, that's our last one. Here we go. Mary, I'm 10 minutes over. I apologize.
No worries. Thank you so much, because it's so important for us to get everybody's input, right? I'm hoping we can make up a little bit of time when we do our data review, because I know that the real value comes from us really being able to get input from this team as we turn to starting to develop the report. So let's go ahead and take a quick 10 minutes and look forward to having you back here at 20 to 11. And we'll still plan on wrapping up right at noon. So thanks so much, everyone. We'll be back in a minute. 11. So here we are. The recording has started again. And let's go ahead and we'll start with a couple introductions. As we know, Kelly had to drop off and Matt has replaced her. Matt, could you please introduce yourself? Perhaps Matt has stepped away. So let's go ahead and turn to Jennifer Seeley. I understand, Jennifer, you are here representing AWIP. Would you like to introduce yourself?
Hi there, I'm Jenny Seeley. I actually work for, let me put my video on. Hi there. So I work for Kaiser Permanente, have worked for Kaiser Permanente for nearly 20 years. And many of those years have been spent in the pharmaceutical supply chain arena and the patient safety and quality arena. So really interested in this work group and the great work that everybody's doing. So thank you for having me.
Great, thanks so much. And I think at this point, turn it over to Ryan. Ryan, are you kicking us off with this next section?
Hi, good morning, everyone. This is Ryan Pistresi again from the Healthcare Authority. So as you know, we brought forward data analysis looking at the Washington State All Payers Claims Database to try to help provide some context and some numbers around the long-term strategies around insulin affordability in Washington. And today, Dan is bringing forward an updated cost analysis that helps kind of take some of the comments that you had made earlier and help kind of address some of the questions that you had. So Dan, if you're ready, you can take it away.
And you're muted. Sorry.
Once again, I always get that wrong. Okay, so why don't we move, we'll try and move through these as quickly as possible. Why don't we go to the next slide? So just by way of background, the research that we conducted into the all-payer claims database was in response to legislation that was passed by the Washington legislature in 2021. It was part of the previous insulin project that fed into this work group project. In July of this year, at your initial meeting, we presented data from that research and got a lot of responses and questions. And so this is a way of closing the circle on that and responding where we can to the issues that were raised back in July. Next slide. July workgroup presentation are summarized here. Basically, it was an acknowledgement that the research was focused on insulin alone, and it did not pick up other costs that are associated with insulin treatment, including the cost of associated equipment and supplies, and other kinds of medications that diabetics may be prescribed that are part of their treatment regimen. The data that we collected from the all-payer claims database was aggregated, and by the rules of our research, we could not get into the specificity around individual insurance plans or payer groups. The data had to be aggregated in ways that met the rules that we were given from the all-payer claims database program. As a result, we had difficulty, and then the claims themselves are organized in such a way that we had real difficulty providing apples to apples comparisons for total payments and patient payments per unit of insulin dispensed. And then also the work group expressed an interest in seeing to what extent there was a connection between the research that we had done and the data research that we had done and the 2019 diabetes epidemic action report. And so we're trying to close the loop on all of these in this presentation. Next slide. So in looking at the action report from 2019, the report focused primarily on identifying the population of individuals who are either pre-diabetic or have diabetes as a diagnosis, and the changes in that population, particularly from the preceding report in 2017. And so there was not a whole lot that we could glean from that report that would shed additional light on cost and utilization of insulin itself. What I did here was to provide some high-level findings from the report that essentially talk about the incidence of diabetes in the state population and its growth over time. I'm going to move to the next slide just because this graphic from the report does a fairly nice job of sort of identifying the population with pre-diabetes, population with diabetes, and then hospitalizations and deaths. And it does provide a total cost. This cost is more of an macroeconomic metric of the impact of diabetes on individuals, and in a way that goes beyond just the cost of insulin itself. Let's move on to the next slide. So I took the information from the action report, the 2019 action report, and tried to overlay it on top of the information that we had from the all-payer claims database. And this graphic attempts to account
So Mike, I don't know if it's just on my side, but it looks like Dan is frozen.
I thought it was my side. Thanks, Mary.
This is Lita, mine too.
I thought it was me.
Well, maybe Ryan can start with this slide. I don't want to put you on the spot, Ryan, but I know that you and Dan have worked very closely on these slides until Dan unfreezes.
I can do my best. So on this slide, we are looking at the different distributions of the population. And so if you start with the bottom, this is the number of patients that had a claim with a commercial insurance in the data period. Going up from there, the next small blue one is the Medicaid population, and just above that is the Medicare population. The blue line that is above that, kind of that maybe hazy blue, are the people not represented in our data analysis. So because the all payers claims database does not get the entire state population, it only gets certain health plans that are required to report. We just wanted to acknowledge that of the data that you'll see in the following slides, it's not representing those that are listed in the top black tier and that second blue tier. So just wanting to keep that in mind as we're looking at the data, that it does not represent the entire state of Washington, just those with the eligible commercial, Medicaid, and Medicare claims.
Thank you, Ryan, for picking up the ball as my Wi-Fi dropped. I'm sorry about that. I did want to jump in here and say that this the top tier of this stacked bar chart is an estimate based on information that is both in the action report and statistics from the Washington Insurance Commissioner about persons uninsured who do not have healthcare insurance. And so it's an estimate, and my guess is that this is sort of on the high end of an estimate of the uninsured population in Washington State that also is diagnosed with diabetes. It was a number that we've been wanting to try and get to for some time now, and so it's being presented here. But I want to emphasize that it's an estimate based on work that had been done by those two organizations. Let's move on to the next slide. So here are the high-level findings that we wanted to bring back to you that sort of address that are based on work that we did, keeping in mind the comments that were made in the July presentation. The focus is primarily on commercial insurance, and here you see that in terms of the three main metrics of utilization that we focused on: paid claims, patients served, and units dispensed, that the commercial plans account for nearly 3/4 of all of that activity. And the table to the right is simply the aggregate numbers from the claims database for commercial claims, Medicaid claims, and Medicare claims. Let's move on to the next slide. it turns out that the increase in claims activity from 2018 to 2020, again, here commercial claims outpace changes in claims from Medicaid and Medicare substantially, and both in terms of the amount of claims that were processed, the patients served, and the units that were dispensed. Next slide. Then we looked at the kinds of insulin that were being dispensed, and this stacked bar chart looks at insulin based on formulations. Long and rapid acting insulin accounted for 80%, more than 80% of insulin use in 2020 based on the claims data. And
Sorry.
Yep.
Sorry, just that, and like Walmart insulin would be considered those short acting and like intermediate acting, I guess.
Yeah, I'm not familiar with what Walmart is dispensing. I'm assuming that Walmart's dispensing activity would show up in the claims data to the extent that there were plans that are covering those just prescriptions were reporting to the claims data, to the claims database, but I'm not familiar with what Walmart is dispensing.
And this is Ryan, just real quick, I wanted to show what chat was saying, that short acting is regular, intermediate is NPH. So does that help answer your question, Kevin?
Yeah, Mike, sorry, this is Kevin Rand. I was just kind of seeing how short acting is prescribed. It seems like it's a very, very small percentage considering.
Yes, that's what, at least in terms of the reported claims to the state in 2020, that's certainly the case. It's a relatively small percentage of the overall claims for insulin. Let's move on to the next slide. And then we looked at the growth in
Jennifer had a question, Dan.
Oh, I'm sorry.
No worries, this is Jennifer. I just honestly, it's more of a comment because right now we see that the regular insulin is a very small chunk of the insulin that is being paid for by Medicare, Medicaid, and private health insurers that you're capturing here. And I've seen some movement towards switching people over to those insulins from the analog insulins. And I just want to point out, I hope this is not a trend that continues because I think that is not the best way to go for a majority of people, because the research is not, the qualitative research, and I don't think the adequate quantitative research has actually been done to show that that is effective. So I'm hoping that we don't move like that in Washington State.
Thank you for that comment. This slide looks at the changes in insulin by these formulations from 2018 to 2020. And again, long-acting insulins are growing at a much faster pace than the other types of insulin that we grouped to get in this report. Next slide. So then we looked at the average payments per claim for these various types of insulin. And what you're seeing here on the left is the insurer payment per claim, and then the average patient payment per claim across all of the insulins that fit into these categories. On the right side, we're looking at the increase from 2018 to 2020 of those average payments. So while these charts say on an average basis, the patient share is relatively small, the increases, particularly in long-acting and rapid-acting insulins, the patient share increases is rather substantial, particularly the long-acting insulins.
Sorry, just to interject. I don't know if it's clear, but usually you would use a long acting with a rapid acting and an intermediate with a short acting or some kind of combination. And then people, I don't know, if you are on an insulin pump, you'd use rapid acting only. So I know that the data might not show that, but that's just kind of the basics. And I think you should follow. Laura dropped a link in the chat too, just to, if you have any questions.
Yeah, thank you for that, Kevin. We have done some, and we did put together some simulated prescriptions to provide an example of how these costs play out. And in those scenarios, we don't have a patient using only one type of insulin. We have them using multiple types of insulin at different prescription levels, so what you get are a blended cost impact for different types of patients based on the insulins that they're being prescribed. The one thing I wanted to note about the average payments here is that the minimum that a patient pays and the maximum that a patient pays based on the claims data varies tremendously based on the insulin that's being prescribed and the insurance plan that they have. Let's move on to the next slide. So then we looked at the insulin products based on product type, and so we had these major product types: auto injectors, vials, syringes, and then a kind of catch-all of other. As you can see here, auto injectors and vials represent, again, more than 80% of the activity, with auto injectors being clear, being provided to the majority of, based on the majority of claims. Let's move on to the next one. And again here, auto injectors, while they're the largest portion of the claims activity, and they also have the highest.
I'm sorry, is that like an insulin pump? I've never heard of an auto injector before.
Ryan, you want to help me out with that?
Yeah, so this is Ryan. So I think these are like the quick pens.
Right.
Yeah. Oh, these are quick pens. These aren't, okay. So
yeah.
Then
So,
what
so
is?
if you, oh, go ahead.
So what is syringes then? Like,
so those are just pre-filled syringes.
Okay, and then
the vials would be
like,
ones where they would draw up the insulin.
Okay, gotcha. Thank you.
Thank you for that, Ryan.
I saw Jennifer had her hand up.
Jennifer has a comment that reminds me of a big important point. The 30-day supply should include both types of insulin if a person is on 2 insulins. I would not want a person to pay double the amount for emergency insulin just because they take 2 types. This would perpetuate disparities. There are disparities in pump use by race, for instance. Charging people double because they can't afford a pump would not be ideal. Thank you for sharing that comment, Jennifer. Let's move on to the next slide. So again, we looked at the cost per claim for insurers and patients. Similar kinds of patterns here as we saw with the insulin formulations. And again, the most popular, the most prescribed type of insulin also had the highest by substantially highest increase in the cost of for the average payment by a patient at 52% over that 2-year period. Let's move on to the next slide. We took a look at, and this is a case where we use these simulated patients. This is a patient with that's taking a rapid acting and a long acting insulin as a part of their treatment regimen. What we did was to look at the insulins that had the highest impact because of the deductible component of their plans. And what you see here is a kind of the average payment per claim for those specific insulins based on the all-payer claims database. So for instance, on the far right-hand column, the total insurer payment for both of the types of insulin combined was over $500 per claim, and the patient component was actually even higher, at almost $600 per claim. The most revealing piece here was just the size of the deductible component, significantly high for these insulins that fall into this for the plans that are paying for these claims that fall into this category. Let's move on to the next slide. What I did here was to just simply show what the increase from 2018 to 2020 in the average cost per claim. And again, you had in this, this indicates that the insurer component actually fell while the patient component increased substantially, and again, driven primarily by the deductible. And then the next slide looks at it on a percentage basis. So you had these significant increases in the patient payment for based on claims from high deductible plans. And in the case of rapid acting, the insulin product that we selected for this analysis actually did not have a deductible for the plans that we were looking at. In 2018, the deductible was a new charge in 2020. Move on to the next slide. And then we looked at what would the cost to an uninsured adult with diabetes, what would those look like based on the claims data for 2020? And so you can see that based on, and what these are the average total payments for these various categories of insulin products. And you can see that the range per claim is from roughly almost $300 for intermediate acting up to almost $1,100 for this category of concentrates. And then on the insulin types, a range from just over $500 for vials to almost $1,600 per claim for powder insulins. And then the far right column just simply takes those payments per claim and multiplies it times the average claims per patient per year to give you an estimate of the total payment per year that an uninsured insulin user would have to cover if the cost was entirely borne by them. I think the final comments I want to make is that the takeaway are pretty obvious that from the claims data that the amount paid by a patient is completely dependent on the types of insulin that they're being prescribed and the plans that they're participating in, and that in looking at the simulations that we did on patients, it was clear that the insulin treatment regimen that they had in many ways was a key, that they had to shop around essentially for plans, if they had the luxury of doing that, shop around for plans that would give them the best payment profile or minimize the payment the patient would have to incur based on the insulins that they were being prescribed. That high deductible plans might make sense for some insulin patients, but not for others, based on the insulin treatment that they were being prescribed. Ryan, did you have anything else that you wanted to add to this? I kind of ran through this very, very quickly.
Hi, this is Ryan. No, I think you did a great job, Dan. I wanted to at least see if any of the work group members had any questions or comments.
Well, good. The data that are on these slides will be, you'll have these data there, and if you have any other questions or want additional data from the research, don't hesitate to ask.
Yeah, and it looks like, yeah, William Hayes has a question in the chat.
Yes, so I think Ryan may want to weigh in on this question about whether we evaluated a difference between type 1 and type 2 diabetes. The way we got to this was in looking at a simulation of for diabetic would be prescribed typically versus what different kinds of type 2 diabetics would be prescribed. So for instance, someone who is newly being prescribed insulin and may be on other drugs would have a different profile than someone, say, a type 2 diabetic who had a long experience with using diabetes. Though their insulin treatment regimens maybe look very, very different. And then the types of insulin that typically would be prescribed to a type 1 diabetic might look different as well. So we did take a look at it in that way, but we did not parse the claims data to separate out type 1 from type 2 diabetics.
Yeah, I was just going to say that this was just the pharmacy claims data. There was no diagnosis attached to it, so we weren't able to do any type of differentiation between, what insulin use is like between type 1 or type 2 diabetes or gestational diabetes.
I think one recommendation that might come out of the work group process might be that and this was a suggestion came up, was to see whether or not the next round of the action report could include analysis on claims or insulin costs or treatment costs more broadly, treatment.
All right, and there is also a question from Ronnie in the Q&A section.
Pardon me?
There's also a question from Ronnie. The categories seem confusing. Are auto injector and syringe and cartridge actually the same? Are cartridges for insulin pumps?
Ooh.
So Ryan, maybe you could take that one.
Yeah, so as you can see on this slide, we do have the auto injectors, vials, syringes, the cartridges, and then the powder, which is like for the inhalation powder. So they are technically different. This is how they were submitted in the all payers claims database. And if you're curious about like specific products, we could take a look and see, but I believe the auto injector, a manufacturer may have their insulin be available as an auto injector or as a syringe or as a cartridge.
That's true.
Yeah.
Yeah, that's true. The characterizations of the insulin products came from the descriptions in the NDC inventory, the National Drug Coding System directory. So that's where I got these where it was able to develop these categories. The categories themselves are not data elements within the all-payer claims database. So these are linked to specific insulin products.
Any other questions for Dan or Ryan on the data?
We have Jennifer.
Hello, I have a comment. I was just reading Mr. Williams' comment in the chat box, and I wanted to point out that type 1 diabetes, as far as I know, is not preventable in any case. There recently has been approved teplizumab, which can delay type 1 for an average of 2 years, and the cost that I saw was over $200,000 for that without insurance. And there's like some like you can try to contact them and if your insurance isn't covered or whatever, but that is not preventable. And then I also wanted to point out with type 2 that is it is not always preventable. And like for instance, I know that some tribes, I can't remember the name, but I know that like half of the tribe has type 2 diabetes. And I think that there's an overemphasis on lifestyle changes rather than systemic changes as the causes of diabetes. And not to say that, not trying to like talk negative. I don't want to hierarchize type 1 and type 2 diabetes as like one being caused by a personal choice and the other as like not, I guess.
Great, thanks, Jennifer. Any other questions for Ryan or Dan?
Laura. And then William.
Great. I just wanted to clarify. So this is Laura with the American Diabetes Association. So when we're talking about like auto injectors, those are often pens, insulin pens, and often they're smart pens now. So they actually kind of work like a smartphone. You can put your insulin information, how much you need to take on that. And a cartridge could actually be for an insulin pump as well. So a cartridge, based on the claims data that I've seen, actually could potentially be like the pod insulin that like sometimes, but it's what you might think, but it's actually not. It's the cartridges. There are insulin pens that you can put a cartridge into a specific type of insulin pen. So there are different ranges of insulin pens. So hopefully that clarifies some of that. So like the syringe is just could be, it's a little confusing, I know, based on these titles for those people who aren't familiar with all the different ways insulin can be delivered. And again, we now have smart pens as well too, which is a newer category of delivery for insulin via also then the cartridges are not used.
I'm sorry, we sort of missed that last part.
Cartridges are not used in insulin pumps traditionally. Traditionally, you have vials that you draw up the insulin to put in your insulin pump. So a cartridge would not be someone most likely that is on an insulin pump. Just wanted to help clarify that if possible.
Okay, thank you.
And then William.
Thank you. I just wanted to make sure that the intent of my question was not to stratify the difference between, and that's why I indicated gray. It's gray between the two. The intent of my question was try to determine if there was any unfairness in the the insurance company's decisions on how it charges people based on the fact that most people who are diagnosed as type 1 or those who cannot produce insulin and absolutely have to have insulin in order to survive, which is who is represented on the call. And I totally understand. And I do want to state, I do have an uncle that is classified as what we call a type 1 diabetic, requires insulin to survive. Are the insurance companies unfairly charging them the same amount of money as an individual who could have prevented a disease? Or, you know, it's an American thing that we don't focus on prevention in our healthcare. We make choices in our lives that allow us to get to the point where we require medications, and we have a healthcare system that, in my opinion, this is me speaking in my opinion, is unfair to everybody, but unfair to some of those that actually require something in order to survive. And that's why we're talking about this. So it was just me seeking out to see if there was some higher level of unfairness to those that absolutely need that medication.
Okay, thank you, William. Are there others? I can't see the names, Nonya, if there are other people with their hands up. All right, so thank you so much, Dan and Ryan, for presenting us the information. Really, really helpful to have. And our sort of our final agenda item here before we get to wrap up is the long-term cost strategies and policy options. So we have 40 minutes left in this meeting. We'll go ahead and go through the policy options. It may be, and we'll play this by ear, right? But I'm thinking it may be that we'll need to do some of the poll everywhere on, you know, that we submit them on our own with comments, and that those are compiled by the center. But we'll hold a good thought that we can get through all of this in 35 minutes and have 5 minutes of wrap up. And with that, Haley, I'll go ahead and turn it back over to you.
Okay, thanks, Mary. I think another option for time could be that we just go over the Washington long-term policy recommendations instead of going over the grid. Is that preferred, Mary, or would you like me to start from the grid?
So maybe we could do the summary box of the grid and then go into the Washington proposals. And if we need to sort of toggle back and forth from there, we can do that.
Great. Okay, thanks, Mary. So this is very similar to the earlier grid I went over, except that this is focused on long-term solutions. So again, we have Maine Insulin Safety Net Program in Minnesota's. They are almost identical except for that licensing fee. And then we have the Utah Insulin Savings Program, which is what we heard about from Travis earlier through the Public Employee Health Plan. Excuse me. The public is able to access those post-rebate discounted insulin. So the elements are mapped out in table 4. Like Mary said, I think we should move to table 5, which is the potential Washington policy, but along the way, I'll highlight where we got certain policy ideas if it's important to tie back to Minnesota, Maine, or Utah. And then this is what we will be polling on, is the potential Washington policy. So as we saw it based on work with HCA as well as the worker feedback, there are 3 arms to the summary of policy, which would be the ArrayRx discount card, ArrayRx voucher program, and manufacturer patient assistance programs, which is what Maine and Minnesota are running. And for people that are new in the work group, there is a great presentation that Lita gave, I think, in meeting 2 about the ArrayRx operations, which is on the website if that's unfamiliar to you. So for the eligibility criteria, the proposed policy would use the current eligibility standards for ArrayRx, which is all state residents, no age or income restrictions, and that would not require ID or documentation of residence. It would just be required to have a Washington address on the form, which we talked about earlier. And so this is for people that are houseless, they could put down a shelter or leave it blank. And also we talked about access to the application and eligibility criteria could be through a public library. That was also a consideration the work group brought up last time. So besides having residence in Washington or an address, an additional requirement for the manufacturer patient's assistant would be targeting families whose income is less than 400% FPL. That is in line with the Minnesota and Maine programs for their eligibility for the long-term manufacturer patient's assistance programs. So the application process, all individuals could sign up online and receive either a digital card delivered to their phone or a paper card mailed to them. This was another lesson learned that Travis shared with us, having the option to have two, not just a digital card for some, but offering both is beneficial. And then getting into manufacturer responsibilities, and this is kind of segmented between discounted insulin through the discount card, the voucher program, and then the manufacturer assistance card. So for the ArrayRx discount card, the legislature could require manufacturers to offer insulin at a discounted price. That would be the responsibility of the manufacturer. Additionally, for the voucher program, manufacturers would bid on the RFP, and then their brand of insulin would be used for the voucher program. And then for manufacturer assistance programs, it's very similar to the emergency supply programs. They would be providing insulin to the pharmacies and then also reimbursing. What's different from the emergency programs is that instead of the pharmacies determining eligibility, the other Maine and Minnesota require the manufacturers to determine eligibility, and the state has oversight. If there's any discrepancies, the patients can appeal and then the state makes the ultimate decision. But with normal operations, the manufacturer is responsible for determining eligibility, and then the patient would bring that to the pharmacy. It was also noted in the other programs that manufacturers are able to send insulin directly to someone if there's a direct mail prescription service. We didn't talk about that with emergency, but it's an option for the long term.
Hey, Haley, this is Mike. Sorry, I just saw Lugina's comment and I thought, Ronnie, if you could scroll back up the top, I think it's really important as we kind of lay this out, right there, as you talk about that three-pronged approach from the policy summary, those three, just making sure we're clear on discount card, voucher program, and patient assistance, right? I think just want to make sure, and Lita, I didn't know if you wanted to weigh in just from an ArrayRx perspective and just make sure that everybody's clear on the differences.
Yeah, thank you, Mike. This is Lita Vasquez. So the ArrayRx discount card has no formulary. Any Washington, Oregon, or Nevada resident can go online and join for free, and you will get a discounted price at the pharmacy that you are responsible to pay. The ArrayRx voucher program can be tailored. So it could only include specific drugs, one drug class, etc. You could tailor it to have a 30-day supply, 90-day supply, etc. And it will have billing information on the voucher that, for example, could be billed to healthcare authority. It could also be set that 100% is billed or leave a copay amount, very specific, that the patient would pay. The manufacturer patient assistance programs would be between the manufacturer and the patient. So that would not be billed to healthcare authority.
And Lita, thanks, that's great. So just to clarify though, the discount card is in place today and it's something that you would be able to continue. The voucher program would be something new that would be specific to this insulin.
Right, the voucher program already exists, but it's customized for each agency, facility, whoever needs to use it. It's very, very much customized. So it's not a program that anybody can join. It has to be set up, and then there is a certain population that can use it.
Got it. Thanks, Lita.
Gina has her hand raised.
I do. Thank you. So the voucher program, I'm just trying to keep these programs straight in my head. So the voucher program would be kind of like what the Utah program is, kind of where you get that post rebate cost savings, or is that?
Yeah, that's what we've looked at, that so since the voucher program, the voucher could be billed to the healthcare authority, then the patient can pay that after rebate price, but the pharmacy paid full price. So the healthcare authority would pay the pharmacy the full price for the medication and then submit claims to the manufacturer and receive a rebate. So get paid back for that full price that they paid to the pharmacy.
And Lita, one follow-up question to that. The difference is, for the voucher program, would people be enrolling if they wouldn't be enrolling in a health plan like they have to in Utah? It would be online process. It wouldn't require like enrollment into a plan, right? That's a distinction.
Right. It's still not health insurance. The voucher program, either the agency or facility that is in charge of that voucher program has to enter the people in, the patients who are participating, or we are looking at maybe we could set up something online where people enroll. So again, this would be something that is tailored for this specific program.
Okay, thank you.
Jenny, I see your hands raised. Jenny Seeley.
Jenny, you might still be muted.
Yes, double muted again. Sorry, thank you for calling that out. Voucher program, the RFP, manufacturers would bid on ArrayRx's RFP. So my assumption is then that if a pharmacy were to participate in this, that we would have to be carrying that specific manufacturer's product. That's one question, but the RFP, will that limit the types, the array, the form of the insulin? So in other words, would we have only certain short acting, certain long acting, that would be certain vials versus syringes versus pens? You know what I'm saying? What are the limitations around that RFP?
Well, we haven't put it out yet, so there are no limitations. It's whatever the legislature says you need to provide this. So then the RFP would say, hey, we need you to give us a discount on your medications, and in return, we're going to give you this many clients. You know, so that's kind of how the RFP process goes. And we can include in there, you need to provide syringes or other supplies in there. So we just have to wait and see what the legislature tells us to do. Legina?
Thank you so much. This is Legina. I just have a quick question. I want to focus on the ArrayRx voucher program because I'm thinking of that as similar to the Utah program. And I'm trying to understand, you talked about HCA paying the pharmacies for the drug, and it sounds like but is that an element of the Utah program, that PEHP is paying full freight and then all the rebate stuff's happening behind the scenes? Or
yeah,
is that how it works?
Yes.
Okay, thank you.
It's basically, Legina, just like to cover the cash flow timing of when the rebates are received. So the state is in Utah, the state is temporarily backfilling that amount.
Okay, because I thought it worked that let's say the cash price is $100 and generally there's a 20% rebate or whatever the rebate is. I thought that cost savings was passed on at the point of sale. I guess I didn't understand the whole funding behind the scenes. So
Yeah, and this is Lita again. The pricing is passed on to the customer, but the pharmacy still paid full price to get the drug in stock. So
Got it.
that's where Healthcare Authority would be paying the full price to the pharmacy and then later receiving the rebate from the manufacturer.
Got it. Thank you.
Really good questions, guys. Any other, I really want to make sure that everybody understands kind of that three-pronged approach, because that kind of is the kind of the layout for those long-term policy options. So it's a good questions. Thanks, Haley.
Yeah, no problem. If anything comes up again, feel free to jump in. So that was, I think we made it through the manufacturer responsibilities, which are different by the three arms that we just went over. So for patient responsibilities, patients would be responsible for enrolling online for the ARX discount card arm. And Lita just went over that could be a possibility for the voucher program eventually enrolling online. They would also check for participating pharmacies, which right now there were 1,200 in the state. And then for manufacturer assistance programs, patients would need to apply directly with the manufacturer, who would then send them a proof of eligibility, which they would then bring to the pharmacy. So there's a little bit more, it's similar processes, but just a little bit different points of contact depending on how they are accessing the program. Pharmacy responsibilities are pretty straightforward. They would receive either proof of whatever part of the program they're accessing at the pharmacy and receive that discounted price. And then like Lita said, the pharmacy would be made whole through the voucher program by the state later. Jenny, I see you have a hand up.
Yeah, and again, being new to the group, you may have already established this, but the 1,200 pharmacies in Washington, is that well dispersed between our urban and our rural areas, or would we need to be working to entice pharmacies to participate in more areas where there's less served for healthcare services?
Hi, Jenny, this is Lita. ArrayRx already has a network of pharmacies across Washington state. I believe there's about 1,100 pharmacies in Washington state, and pharmacies all over the US can be used. For participating pharmacies, I could give you the link to the discount card where you could look up, you could put in a zip code and see what are the participating pharmacies in that area. We have, chains like Safeway, and then there's also small independent pharmacies that are included that are in rural areas or the islands. I'll put that link in the chat.
And I would just add that 1,200 pharmacies would represent almost all of the community pharmacies in Washington state. So that all of the available options would be included for the most part, if that was the correct number.
And that's Jenny Arnold, right?
Oh, that Jenny Arnold with Washington State Pharmacy Association.
Thank you.
Thanks, Lita, for that explanation. This is Haley, and I just would want to address Jennifer Perkins' question or comment in the chat. I support ArrayRx, but would like to see support for CivicRx and/or California's manufacturer mentioned as an option for long-term support. More manufacturers, the better. We didn't include it specifically called out in the table, but correct me if I'm wrong, HCA team and center team, but I do see CivicRx in the California. Oh, Mary, did you want to jump in on that?
Nope, go ahead.
Oh, okay. They're kind of options that are still alive and embedded in these policies because CivicRx could be a potential bidder on the RFP. Isn't that correct, Lita? So if we go through the voucher or the discount card, manufacturers, we're not limiting any potential manufacturers. Is that correct?
Right. And again, the RFP hasn't been put out, so we can ask for whatever we want to ask for. we haven't been directed yet by the legislature exactly what we're supposed to do. But yeah, we can ask for multiple manufacturers. We could say all manufacturers, we could say whatever we need to do. I think it was at Minnesota that the legislature directed manufacturers to participate.
Mm-hmm. Yeah, I think they have a limit on it. They must be producing a certain amount, or must be selling a certain amount of insulin in the state, but they did direct them.
Yeah.
Okay, thanks, Leah. And thanks, Jennifer, for your question. So moving on to the reimbursement process for the potential long-term policy, we did discuss this, that HCA or the whatever.
I'm sorry, Haley, could we please bring up the grid again?
Yes. Can you not see it?
Oh, there it is. Thank you. So sorry.
Okay, let me know if it ever goes away.
Gracious.
So for the reimbursement process, we did mention that HCA or whatever state agencies over the program would have to temporarily backfill to make the pharmacy full while they're waiting for the rebate. For the patient assistance program, manufacturers would be responsible for reimbursing pharmacies directly, like we've talked about.
Haley, I know we're going super fast through this because we want to get to those questions, but I think at this point, we really appreciate the questions that we get and the ability for this team to really understand. I mean, this is our long-term strategy. So we're thinking that it may be better for us to just take our time to go through and really understand what these options are, and then to administer the survey after this meeting. And hopefully people will take the time to, while it's still fresh, to answer and respond to the survey questions and provide also comments via email. So could I just get a sense of the group if that process works? Knowing that we only have 20 minutes left.
This is Lori Evans. Sounds good to me.
Great. And Jennifer, I see thumbs up. Terrific. William, thank you so much. All right. So if you're opposed, go ahead and put that in chat, and we'll try to revisit. But Haley, I'll turn it back over to you. And so we talked about the voucher and we talked about the discount card. What is the third prong of the three-prong approach? Just want to make sure we're all thanks, Lumi, all super clear on kind of all three of those.
Okay, yeah, great. Thanks, Mary. For the third option prong, I guess, is the manufacturer assistance program. And to describe that, I actually scrolled back to our long-term solutions grid because I do think it will, we can look to Maine and Minnesota for a quick overview of what that policy would look like. So same eligibility criteria that we've been going through. I'm going to skip that. But the application process, so individuals would apply directly with the manufacturer. So these are manufacturers that are operating in these states. Both of the state bills did require a certain volume of insulin sold. So smaller manufacturers do not need to participate in this program, but if you sell above a certain threshold, which I don't have off the top of my head, but it's in the legislation, then they're required to participate. So the manufacturer is required to offer a long-term patient assistance program in the state. Through that program, the manufacturer is determining the eligibility of the patient. They work directly with the patient to get any extra information required for the application. Once they approve it, they send the patient a proof of eligibility, which is what that patient can bring to the pharmacy to access the 90-day supply of insulin, which is the typical order. I think you are able to order a lesser amount, but I think typically it's 90 days through the manufacturer program.
And the real distinction here between the voucher program. So the voucher program is the patient gets A, the discount that's been negotiated with the pharmacy, and B, the rebate that the HCA, if that's how the legislature sets it up, receives. So they pay a lower price. Under this program, however, the patient pays nothing, but needs to meet the criteria around federal poverty level and no other coverage. So those are really the key differences. Is one is a means tested program, and the other is not means tested, and yet there is a payment obligation under the voucher and not under the assistance, which is why we're thinking we would want to take advantage of both, continue with the discount card, introduce a voucher program, and then also obligate the manufacturers to comply with the with a safety net sort of program like Maine and Minnesota do. Okay, thank you so much.
No, thank you, Mary, for laying it out that clearly. That was, I think, very helpful. So the point is that the reason you might be wondering why there's 3 prongs, it's just like Mary suggested. It's so that you're covering as many people as you can through the different avenues that are already available to the state. For the reimbursement process, the manufacturer again would be responsible for reimbursing the pharmacy for the 3rd patient's assistance program. There's educational materials. I'm just going to see if there's any other major points to point out. The state does have oversight, like I said, of the application process if there is an appeal. And that seems to be the main entity or state entity responsibilities. So another thing to note for the program comparison, table 4 is that these programs in Maine and Minnesota do have expiration dates. Maine's is repealed January 1st, 2027, and then Minnesota is 2024, but does leave an area if the legislature were to vote to continue that it would. And we also included in this table links to the manufacturer assistance programs in each of these states, as well as this was a question earlier about which types of insulin are covered by the Utah program. The brands are listed here, and also I put in the chat a little bit ago a link to their flyer. So that's the background for the manufacturer patients assistance program. I'm going to pause one more time and just see if anyone has any questions about the overlap of those 3 policies or any of them in particular you want to talk about before we continue going through the grid. Okay, I'm not seeing any. So where did we? I think we left off at the educational assistance, which we included a policy recommendation to include educational program and information sheets to anyone who is accessing this program to identify individuals that might need help overcoming other barriers. So the state entity responsibilities, the state entity, work group members agreed to prioritize access to state negotiated insulin prices through RARX as the top policy option. RARX right now has interagency participation from Washington, Oregon, and Nevada state agencies. I put this on here because we did get feedback originally from the work group about prioritizing state negotiation power by teaming up with other states. And RARX has participation from multiple states. So just wanted to highlight that. So if this policy option were to go forward, RARX would go out for bid for a preferred price of insulin and work with the discount card to get that discounted price available. The voucher program would be an additional arm of that where the customer would get access to that post rebate price at the pharmacy.
And just to be clear, Haley, that work group that you're referring to is not this work group. So it's not this work group decided this in other meetings, but it was the work group that we conducted in 2021, correct?
Well, this work group, I think at the first meeting we did offer 2 ranked choices of working with the RARX or multi-state negotiating power.
Gotcha.
Either in the first work group meeting or the second, there was a survey.
Very good, thank you.
And so the HCA or whatever the state entity overseeing the program would also need to close that cash or cover the cash flow gap with state funds until the rebate is secured. So that's the state entity responsibilities. As you can see, all of these are related to the first 2 options. The manufacturer assistance program goes independently through the manufacturer and involves some state oversight, but not to the extent of these options. So the work group requested, and I the first, or I believe probably the second meeting, but maybe the first, transparent financial disclosures from manufacturers, PBMs, and plans regarding what the plan paid, member paid, rebates, acquisition costs. So basically we heard from the work group that they were exploring data, or they wanted to prioritize exploring data transparency efforts. We did hear from the HCA team that this would require an exception to the current Washington drug price transparency program, but we did include it in this policy because it was a resounding opinion of the work group. We did not include any program expiration dates, like that, which is not like what Minnesota and Maine have done. They have put expiration dates on. And then the last row for this table is the other notes. We wanted just to highlight that Array RX could also be used for the emergency supply of insulin if the Washington legislature enacted the same law directing insulin manufacturers to provide a discounted cost for emergency supply. We didn't really talk about it directly within the emergency supply, so we wanted to note it here. And then another consideration would be providing patient navigators as part of that educational assistance, like Minnesota has done. They did appropriate significant state resources to get that program trained and up and operational, but wanted to leave that as another consideration that we heard from the work group, how important educational resources are for navigating the system. So that's the end of the grid. So I think the plan is that the survey will be sent out to gather support for each of these elements, just like we went through earlier in the meeting, but this will be that reference table for you of all the pieces that the survey will touch on. Are there any questions about the full table 5 potential long-term policy or anything related to the grids?
Haley, this is Mike. I would just add on. So again, thank you for taking time to go through that. I think just getting that level of clarity is really helpful. Just to verify on the survey that will come out. So I think it's going to work fine. So we'll come out with a survey as soon as possible. We'll make it into this this platform that you guys have used before. But basically, like you've just done on the prior short-term emergency supply options, for every element, we'll have that Likert scale 1 to 5, but also we'll leave a place for you to provide comments like you just did in the chat, because we want to make sure we don't lose that. So that'll be coupled. And then we'll be able to come back and have that as a agenda item for meeting number 5 to really kind of talk through some of the details around that, which I think will be helpful. And Haley, thanks again for all that. It's great.
Yes, Haley, really appreciate that great description. And I also want to circle back and make sure the question was answered around the potential of California insulin being included, or the other insulin that we've talked about, the Civica RX solution. So does anybody have any questions about that sort of how those discounted manufacturers would interplay with this program? I think I could tell everybody is at the end of a 3-hour meeting that was just jam-packed with great discussion and lots of information. So that I also sort of think about, well, how would it work with Civica? How do we really make sure those manufacturers that are coming in with deeply discounted prices, we have an opportunity through our systems to appropriately recognize them and make sure that they are being made available through all of the appropriate systems, and that we're taking advantage when we have low-cost manufacturers entering the market. And I guess my other question, and it's sort of for the team at large, when you think about this 3-prong approach for the manufacturer, the long-term solution, is there anything that you would change or have comments about in terms of the short-term solutions that we talked about? I know we had a lot of rich conversation about that. And Lugina, I see you have something in chat here.
Yeah, sorry, my comment in chat, this is Lugina, my comment in chat I know the table's very, very helpful, and I know there's a lot of data you're trying to present, but if we could just have a quick, couple of sentences on what the discount card is, what the voucher program, patient assistance program is, to help us as we're answering the questions that will be coming to us, that'd be really helpful.
Okay, terrific. Any other comments? And Mike, Haley, is that something that we can make available to this group as we move forward with sending out the survey?
I like that recommendation, Legina. I think not only with the grid, but something we can work on quickly to kind of accompany that is just a little bit more detailed description of those three. So yeah, we'll circle back on that.
Awesome. Great, thank you, Jennifer. All right, with that, let's go ahead and move to wrap up. Can we bring the agenda back up to the screen? Great, thanks so much, Ronnie. All right, so we talked about, we had Travis, it seems like it was a long time ago. We had Travis talk to us about the Utah model. We went through the short-term emergency supply strategies. We got our cost analysis, and we went through the long-term cost strategies, and we will do our poll everywhere, including a summary after this meeting. And in terms of next steps, we have a report due to the legislature on July 1st. And within our processes, that means we need to submit our first draft so it can go through all of the reviews it needs to go through 2 months prior. And so we will be submitting our draft for that process of review and approvals by mid-April. So we will be having our last meeting on March 16th. We'll be bringing forward our the information that we've received from this meeting, from the information that we'll be getting. I really liked, Sherry, I think it was you that had the recommendation around asking medical providers about the impacts of not being informed when an emergency supply is filled. So I think we need to sort of track that one down also, and we'll be starting to draft the report. You will be receiving a version of that, and that's what we hope to talk about in pretty good detail on the 16th. And then after that meeting, we will be incorporating your feedback, and as I mentioned, getting it through the approval process. There will probably be more review opportunities for you within that time period, but just wanted to recognize that our time is sort of coming to a close here, that the legislature asked us to do two things, right? It's the once a year 30-day supply, as well as the long-term cost strategy. I think we are in a good position to answer both of those questions, as well as enhance some of the some of that around, does it have to be once a year 30-day supply, as we talked about earlier. So really appreciate everyone leaning into a 3-hour Tuesday morning meeting. And with that, I will just ask if there are any other final questions or comments, Nonya, Ronnie, others, things that we've forgotten or we should make sure we let this team know about before we wrap up.
Nothing from me.
Mary,
Right.
I would just say that the email, the survey information, survey link and all that will come, Nonya, most likely from you,
Yes.
correct?
Yes,
Yeah.
yes, it'll come from me.
Great,
Yep.
great. You can expect
All
that.
right. Great. Thanks so much, everyone. Be looking for that message from Nonya, and would appreciate, again, a quick turnaround time, just so we have all of this information fresh in our minds in this great discussion. And please make sure you also provide Nonya with any comments you have as you go through that, since obviously it won't be in the chat function here. And with that, I hope everyone has a wonderful holiday season, and we look forward to seeing you in the new year. Take good care. Bye-bye.
Thanks, guys.
Bye. Thank you.